This is a video of a routine cataract surgery performed by myself a few years ago. We'll start here with an initial incision called a paracentesis performed with a 1 mm side port blade, followed by installation of epi-sugarcane, a mixture of lidocaine and epinephrine. A dispersive viscoelastic called Viscoat is then injected. The intended audience for this video includes patients, students, and residents interested in my technique. A temporal clear cornea incision is being made now with a 2.4 mm keratome, which is then followed by a cystotome used to initiate a capsulorhexis, which is an opening in the transparent capsule that surrounds the cataract, much like saran wrap or shrink wrap. The capsulorhexis is completed with forceps in a continuous curvilinear fashion with a goal to make the hole round in shape, perfectly centered, and big enough to easily remove the cataract, but small enough to capture and hold the optic of the artificial lens in place. This step can also be performed with a femtosecond laser, which can make the opening more perfectly circular and guarantee centration, which has some theoretical advantages. But in experienced surgeons' hands, it's debatable whether this really has an impact on outcomes. It may, but it's difficult to ascertain just based on numbers. I then perform hydrodissection, where a stream of balanced salt solution is injected via cannula just under the edge of the capsulorhexis to free the nuclear or firm portion of the cataract from the surrounding capsule or the shrink wrap to allow it to be mobile and spin freely. As noted above, this case is being done without the aid of a femtosecond laser, which can be used to fragment the nuclear cataract to decrease the amount of energy it takes to remove it out of the eye. So my strategy is to accomplish something similar to what the femtosecond laser can do by dividing the nuclear portion of the cataract into bite-sized chunks with a technique called vertical chopping. I lollipop the nucleus with the phacoemulsification handpiece on burst mode with axial ultrasound under very high vacuum, and then use the vertical quick chopper to cleave the cortical or the nuclear cataract into progressively smaller pieces. These small pieces, usually 6, can then be emulsified with phacoemulsification, torsional ultrasound, while expending very little total energy inside the eye. I think the femtosecond laser may have some value in extremely dense cataracts where its pre-softening action before the cataract surgery may help to decrease the amount of total energy used to remove the cataract. But here in this case, with just a moderately dense cataract, the femtosecond laser action on the nuclear cataract would likely have been only of modest benefit. Some instances where femtosecond laser may have benefit are in patients with pseudoexfoliation or trauma, where there is some zonular loss leading to instability of the lens and its suspension inside the eye. Such instability can sometimes make the capsulorhexis step more difficult, so having it accomplished by an automated laser could make the surgery a little safer. This patient did not have any noticeable instability nor any prior history of pseudoexfoliation or trauma. Also of note, this case is unedited, but it is sped up 2 times to make it more palatable to watch. After the nuclear cataract is completely removed, the stringy remnants of the cataract, called cortex, which is stuck to the capsular bag, or the shrink wrap, if you will, are stripped off with an irrigation aspiration handpiece. As you can see, this handpiece does not have any sharp metal edges and thus is very friendly to the very thin and friable capsular bag, the integrity of which is very important to ensure a good, stable place to inject the artificial lens. The anterior chamber and capsular bag are inflated with Provisc, a viscoelastic, and then the intraocular lens is injected into the capsular bag. Here, an Alcon AcrySoft SN60WF lens is being used to match the lens that had been placed in the other eye because of its unique, slightly yellow tint. Matching this to both eyes will help prevent any asymmetry in color perception, which could potentially be bothersome. The Provisc is evacuated using irrigation and aspiration handpiece, with care being taken to remove the viscoelastic from behind the lens as well. The wounds are hydrated with balanced salt solution on a cannula to seal them shut and achieve a watertight closure. And the surgery is complete. Thank you for watching the video.